Here's an example of a patient with a moderate to severe hallux valgus deformity and crossover a second toe. Notice the increased IM angle, the incongruent joints. Here's a setup for the MIS setup. We place the burrs and the devices on the table. The foot is taken off of the operating room table and resting on the C-arm as a working surface. I place my first pin under fluoroscopic guidance to ensure that it is in proper position. My pin needs to come out on bicortical, out of the lateral cortex as well. Bicortical fixation is crucial, checking the fluoroscopy under AP and lateral to ensure that the pin is exiting the right position. I then place my burr just proximal to the sesamoids, create a working space to protect the extensor tendons, try not to strip the soft tissue. A Shannon burr is then used. Notice I am aiming towards the second metatarsal, plantar flexing at slightly about 20 degrees. When I cut the dorsal limb of the osteotomy, which in this case is transverse, I dorsiflex the toe. When I do the plantar limb, I plantar flex the toe. I try to stay in line with my osteotomy, minimizing trauma to the soft tissue. Once the osteotomy is completed, I use a translation tool to push the metatarsal head over. I'm also rotating and adducting the head. By rotating the metatarsal head, the sesamoids are relocated. Pulling the toe into varus ensures that the toe stays straight, and the translation tool holds it into position as the pin is advanced into the metatarsal head. This is checked under fluoroscopic guidance. A small beaver blade is used to make an incision to measure the length of the screws. The pins are advanced, and the screws are placed into the metatarsal head. We use beveled screws to ensure that they are flush with the medial cortex of the metatarsal. Again, at least one screw needs to be bicortical, coming out of the lateral cortex. The second screw is used for rotational control. The Akin osteotomy is done in a similar percutaneous manner. The guide pin placed initially, checked under fluoroscopic guidance. A Shannon burr is used to make a Akin osteotomy perpendicular to the pin. It's closed down until adequate correction is obtained. The pin is then advanced out the lateral aspect of the toe. I clamp and hold it in place with a hemostat so that when both cortices are drilled, which is essential, the pins don't come out with the drill bit. A screw is placed. Again, bicortical fixation is important to hold my reduction and not displace my Akin osteotomy. Finally, the overhanging bone needs to be removed. I use an elevator to create a working space to move the soft tissue out of the way from my burr. The overhanging bone needs to be removed with a burr, and I do this from an inside-out technique, protecting the dorsal medial cutaneous nerve and soft tissues. The burr is placed from the plantar aspect of the overhanging bone and brought dorsally to remove the fragment and any prominent bone. Manually, you feel for any prominent bone, and if there's any remaining bone to be removed, the burr is used to remove this as well. My reduction is checked under fluoroscopic guidance, and my decompression is confirmed, both clinically and radiographically. If the sesamoids are still dislocated and the toe needs further correction, a beaver blade is used to do a percutaneous lateral release through a small perc incision in the first web space, releasing the sesamoids in first web space. Any remaining bone fragments are removed using a rasp and pushed out of the small percutaneous incisions. Small fragments of bone can be removed as well. Postoperatively, patients are allowed to weight bear as tolerated in a boot. Here's a finding 2 weeks. Notice the incisions are virtually healed. By 6 weeks, there's minimal swelling, minimal pain, full range of motion, and by 6 weeks to 10 weeks, the radiographs show complete healing.